Hello class, it's time to start our discussion on diabetes mellitus, also known as diabetes mellitus. Either way is the correct pronunciation. Some background on DM. DM is not a single disease but a group. It's a constellation of disorders with glucose intolerance as the common factor. It encompasses many casually unrelated diseases and includes many different etiologies of disturbed glucose tolerance. We will explore many of these. Historically, diabetes was a disease distinguished by weight loss and excessive urination, thirst, and hunger. The disease was recognized in at least two forms, one common form that affected primarily obese individuals, and another less common form found primarily among younger, thin individuals. The term DM is now used to describe a syndrome characterized by chronic hyperglycemia. That means high blood glucose levels and other disturbances of carbohydrate, protein, and fat metabolism. In 1979, the World Health Organization, or WHO, published classifications based on a combination of clinical manifestations or treatment requirements, for example, insulin-dependent and non-insulin dependent, and they called these IDDM and NIDDM respectively. Since then, we have a new classification. It is not okay anymore to say juvenile onset nor adult onset diabetes. Our youth are getting obesity-related diabetes, and even our elderly can get the juvenile onset. So age is not a good distinguishing factor. The old terms of insulin-dependent DM and non-insulin-dependent DM, shown down here at the bottom of the screen, shown as IDDM and NIDDM, can't be used anymore either. The reason is because so many of the type 2 diabetes that I'm going to tell you about that were traditionally thought of as non-insulin dependent, well, now we do treat the patient sometimes with insulin. So the fact that the patient is on or not on insulin is not a distinguishing characteristic, because a lot of patients with type 2 diabetes can be having insulin therapy. We're focused now on type 1 and type 2 diabetes and the, quote, other types, different genetic defects, and also gestational diabetes, which I will talk about. Anyway, just some interesting facts on DM. Although the exact cause is unknown, type 1 DM accounts for about 10% of all the DM patients in the Western world. Several studies suggest that the occurrence and incidence are higher for whites than non-whites, with the highest rate found in Finland, of all places, and the lowest rate in Japan. Diabetes type 1 is thought to be a genetic environmental interaction. In other words, the person has a genetic predisposition, but then something in the environment changes and causes the presentation of the disease. Interestingly, diagnosis has a seasonal distribution for type 1. More cases are reported during fall and winter seasons in the northern hemisphere. And diagnosis is rare among the first 9 months of life and peaks at 12 years of age. So currently in the U.S. we have 20 million plus patients with DM. About 1 million of them accounts for type 1. Of the 20 plus million that have diabetes, it's estimated that 54 million more are pre-diabetic, meaning they're on their way. Most people who have been diagnosed with diabetes have had it 5 to 6 years prior to being diagnosed. That means there's 5 to 6 years of damage being done to their body, which is retinopathy, nephropathy, and neuropathy. The purpose of this slide is to review our glucose, fat, and protein metabolism, and this relates to absorptive states and post-absorptive states. I want to remind you that our body uses glucose, fatty acids, and other substrates like amino acids as fuel to satisfy its energy needs. And we need to remind ourselves that the brain cannot synthesize, nor can it store a lot of glucose. So it requires a constant supply of glucose. Other body tissues, and the big ones to focus on are liver and skeletal muscle, can store glucose as glycogen. Glycogen can be hydrolyzed so that individual glucose monomers can be used for fuel. The liver can hydrolyze glycogen and release free glucose monomers into the blood. Skeletal muscle cannot release free glucose from its stored glycogen. It lacks the appropriate enzyme, the glucose 6-phosphatase. When skeletal muscle burns or uses glycogen, it's for its own internal purpose, and once it goes through that stored energy source, it has to turn to alternative fuels. Triglycerides are stored in adipose tissue. Adipocytes have a lipase where they can take triglycerides and release free fatty acids into the bloodstream along with glycerol. The free fatty acids can be used by the liver as an alternative fuel source, and the glycerol can be used for gluconeogenesis. Amino acids found in the skeletal muscle can be released by the skeletal muscle, and that can go back into the bloodstream, and the liver can convert those amino acids to glucose through gluconeogenesis. Absorptive states are within the 3 to 4 hours of eating a meal. Of course, we have a lot of glucose supply, and the cells of the body focus primarily on using that glucose as a fuel source or storing it as glycogen. Then, about 4 hours after a meal, we switch to a post-absorptive state. I'll remind you that most of our proteins in our body are fixed, which means they're fixed in place. They are intended for structural support, not as an energy fuel source. Our primary alternative fuel when glucose is not available is, of course, fatty acids. They give us more bang for our buck, too. They provide 9 kilocalories per gram when they are used as fuel. The pancreas is a mixed gland. 90% of the pancreas is exocrine by function. The acinar cells are making digestive enzymes, releasing them through the pancreatic duct, and this gets to the duodenum of the intestine where it mixes with chyme, your gastric contents. The other portion of the pancreas is endocrine by nature, and in this picture you are seeing yellow cells that are the pancreatic acinar cells, the exocrine function of the pancreas. And in the middle you are seeing a cluster of cells that are purple, pink, and blue. This represents an islet of Langerhans. Inside this little cluster of cells we have different cells. The purple cells are labeled as the alpha cells. The pink cells are labeled as the beta cells. In blue, you're seeing delta cells. There are even more cells now that we've discovered, F cells as well. What I want you to know is the alpha cells release glucagon. The delta cells are going to release somatostatin, and another term for somatostatin is growth hormone inhibitory hormone. Somatostatin released by the pancreas is basically a way for the pancreas to control overall gut motility and slow it down. Glucagon is our hormone during post-absorptive states. It's our glucose-sparing hormone. Insulin is released by the beta cells. Interestingly, insulin is made as a propeptide, which means it's made in a version or a form that needs further processing before it's active. Now, the insulin is actually stored in granules, little membrane-bound cytoplasmic pockets, if you will. Before insulin is activated, it needs this connecting peptide, shown here at the bottom of the screen, in green to be cleaved away. The active form of insulin has an alpha chain and a beta chain, and it's actually the connecting peptide that we measure clinically as a direct correlation of how much insulin is being released. So we don't actually measure true insulin levels, rather the connecting peptide that's cleaved from it. It's a 1-to-1 ratio, so it's fine. Now, the beta cells, in addition to releasing insulin, they also release a hormone called amylin. Amylin is very similar to GIP, another hormone of the duodenum. GIP is also known as glucose-dependent insulinotropic peptide. We either name gastric inhibitory peptide or the other one give the initial GIP. So amylin works a lot like GIP by reducing the rate of gastric emptying, and it also inhibits glucagon release by the alpha cells. Now, interestingly, amylin tends to accumulate and cause these plaques that have been detected in the pancreas of type 2 DM patients. Because of this, amylin has been used as a diagnostic marker when it builds up aberrantly in the pancreas for type 2. The basic function of insulin is it's going to promote, in general, glucose uptake from insulin-dependent cells. It's also going to prevent fat and glycogen breakdown. Basically, this is our absorptive state hormone. It's also going to inhibit gluconeogenesis. Also, and this is really important, insulin directly affects the sodium-potassium ATPase. Insulin will directly stimulate this pump to cause potassium to be pumped into the cells. it causes an intracellular shift of potassium. Insulin can be used to help the hyper-K patient because it causes that intracellular shift. Insulin is also very much needed for amino acid intake. You should be hearing right now, insulin isn't just for glucose. It's for potassium, glucose, and amino acid shifts into the cell. Alright, so let's explore insulin a little bit further. The way it's released is pretty awesome. Before I get to the mechanism of insulin release, let me just point out this very handy little table from your textbook, which compares and contrasts the actions of insulin and glucagon on our glucose, fat, and protein metabolism. If you quickly look down this list, you'll see that insulin is our absorptive state hormone. All actions of insulin promote intracellular shifts. Glucose goes in, potassium goes in, amino acids go in, and glucose is used for fuel. Metabolism of all the other alternative fuels, protein metabolism, fatty acid metabolism, those processes are going to be halted. Times are great. We've got lots of glucose. Let's use it. Then if you look at glucagon, it's our post-absorptive hormone. It's when we're in between meals. Times are hard. Glucose is not abundant. We need to use our alternative fuels. Proteins, which are not our usual go-to, and fatty acids. Fatty acids give us a lot of bang for our buck, but they're more difficult to mobilize because they're not water-friendly. They don't like to be in the bloodstream. Proteins. Most of our proteins, like I said before, are structural, so we really don't have very many free mobile sources to tap into. Finally, the slide on how insulin is released. In the top right picture, you're seeing a gray box, and that represents the beta cells in the pancreas. Now, it turns out that when we're talking about glucose transporters, there are many types of glucose transporters, 13 different known types. Some are found in specific parts of the body. Some are inserted into the cell membranes only after certain chemical signals. Some are constitutively expressed, which means they're there all the time in a cell and inserted all the time in a cell membrane. And some glucose transporters are bigger than others. Most notably, there is a glucose transporter 1, GLUT1. It turns out this is present in all the tissues, but in most tissues of the body, it is in the cell membrane in very little amounts. And this transporter allows the free diffusion of glucose. So hear me on this. Glucose can enter your insulin-dependent cells through this transporter, but it's just so few in number that the amount of glucose it allows into the cell is not enough to meet the cellular needs. GLUT1 is present in high abundance in nervous tissue, and that's the reason why the nervous system is not insulin-dependent and has sufficient permeability to glucose so that the glucose from the bloodstream can readily diffuse into the neuron. Most cells of your body, skeletal muscle, and adipose tissue are going to require GLUT4. The problem with GLUT4 is the transporter is not inserted into the cell membrane until after insulin is released. So the question is, how do we get insulin to be released? Well, enter the beta cell, the gray cell in the top right picture. Now these beta cells have a different glucose transporter. They have GLUT2. GLUT2 is the major transporter of glucose for the beta cells and liver cells. It has a low affinity for glucose and acts as a transporter only when plasma glucose levels are very high, say after a meal. So when you eat, the glucose levels are high. This favors glucose to diffuse into the cells. Interestingly, the beta cells use this glucose in normal cellular respiration. We're talking glycolysis, Krebs cycle, and the electron transport chain. And the end result is the beta cell now has a more robust supply of ATP. Follow me on this. The more glucose from the meal that enters the beta cell, the more ATP the beta cell has. The more ATP they have, the more they can phosphorylate this ATP-dependent potassium channel. It's actually a leak channel where potassium is constantly diffusing out of the cell. So the ATP phosphorylates it, and this traps potassium in the cell. It's going to favor the net gain of potassium inside the cell. And that's what this picture is showing you with the arrow showing potassium entering the cell. What will happen to the cell membrane potential? If we have more positive charges being trapped in the cell, that means we are going to depolarize, become less negative, more positive. When that happens, this is going to reach the threshold for the opening of calcium voltage-gated channels. The calcium voltage-gated channels open, and calcium can diffuse into the cell. This starts an action potential in this glandular cell. Beta cells can change their resting membrane potential and have action potentials to release insulin. Granules that are filled with insulin are going to fuse with the cell membrane and exocytose. And I'll remind you that these insulin granules also have that connective peptide that's already been cleaved. That connective peptide is also released into the bloodstream. And although it does not have any physiologic effect, we can actually measure that connective peptide to get an idea of how much insulin was released, because the connective peptide to insulin ratio is a 1-to-1 ratio. Now, interestingly, when you first eat, there is a first phase of insulin release. That's the acute phase. That reflects the insulin that was already made and packaged in these granules. Then, as your meal continues, there is going to be a second phase of release where the meal produces more glucose in the blood, and then a second release phase of insulin. So our insulin release is bimodal, an acute and then a longer lasting phase. The insulin that is released into the bloodstream goes straight into the hepatic portal vein, straight to the liver, where 50% of insulin is immediately degraded by the liver. Insulin only has a 15-minute half-life. These two pictures are from your textbook. The picture on the left is showing you the insulin receptor, shown here in purple. The insulin receptor has 2 beta peptides and 2 alpha peptides. You can see the beta peptides are transmembrane proteins. The alpha subunits are extracellular, and they are the subunits that are going to bind to insulin. When insulin binds, the beta subunits have a kinase enzyme associated with them. This is second messenger signaling at its best. When the kinase is activated, it's going to phosphorylate proteins. That's what a kinase does. It puts a phosphate group onto proteins that's different from a phosphatase. A phosphatase takes away phosphate groups. So the beta subunits have this kinase. They're going to add phosphates. And when that happens, that kind of supercharges a lot of enzymes. So we're going to see this in the absorptive response. We're going to see more glucose intake. You're seeing, as a result of insulin binding to the alpha subunits, on the left side in orange, the glucose transporter 4 protein being inserted. And also on the right side of the receptor, you're seeing a blue amino acid transporter. As a result of insulin, that not only glucose is entering the cell, but also amino acids. Now on the right side in this picture, you're seeing the insulin-dependent glucose transporter 4, GLUT4, being inserted into the cell membrane, with step 1 being the binding of insulin to the insulin receptor on the surface of the cell membrane. That leads to the tyrosine kinase and the beta subunits becoming activated. That's that intracellular signal, second messenger cascade I was telling you about. That leads to phase 3, the insertion of the receptor from its inactive site in the cytoplasm into the cell membrane. Ultimately, as a result of that, there will be transport of glucose into the cell. Now it's time to remind ourselves of our counter-regulatory hormones, hormones that are antagonistic to insulin. Of particular interest are catecholamines such as epinephrine and norepinephrine. Cortisol, which is a glucocorticoid, glucagon, and growth hormone. I just want to remind you that when insulin levels are low in the post-absorptive state, then catecholamines, cortisol, glucagon, and growth hormone levels increase. On this right-hand slide, I'm showing you the effects of glucagon individually, cortisol individually, and epinephrine individually. They're shown in the bottom of that picture. What you're seeing with the higher graphs with glucagon plus epinephrine or glucagon plus epinephrine and cortisol, that they have more additive effects. When all of them are mixed together, we have a potentiation, which means 1 plus 1 plus 1 plus 1 do not equal 4. They equal 4,000, as an example. It's a multiplier effect, really, not additive. We don't really think of growth hormone as a stress hormone, but it could be, because growing is stressful to the body. These hormones share an increased release of fatty acids and accelerated gluconeogenesis and ketogenesis as a response of glucose reuptake. All of them, but one, are going to stimulate the breakdown of proteins. The only one that will not stimulate the breakdown of proteins to amino acids will be growth hormone. Growth hormone actually promotes amino acid intake by skeletal muscle and promotes protein synthesis. But in general, these 4 hormones are going to counter the effects of insulin. In the bottom left picture, shown in the purple box, I'm showing you the principal pathways of the post-absorptive state. As I said before, when we say the term diabetes mellitus, it is used to describe a constellation of chronic hyperglycemic problems. There are disturbances of carbohydrate, fat, and protein metabolism. What's the problem? What's the disorder? We don't have adequate usage of glucose as our primary fuel source, and the cells are relying too much on protein and fat metabolism. That's where the disorder is. It all comes down to a problem with protein, fat, and glucose metabolism. So when we say DM, we are really talking about the whole gamut of problems. Not making insulin but it's faulty, making insulin but you can't release it, making insulin and you're releasing it but it's destroyed too quickly, making insulin and releasing it but you don't have a receptor, making insulin and you're releasing it and you have a receptor, but the cell is not responding appropriately to it. Again, you're going to get DM as a result, which means high blood glucose levels. You're not able to internalize glucose into skeletal muscle, adipose tissue, and the liver. The liver also needs to be included in this. So in the right-hand picture of this slide, I'm showing you the 2 general paradigms for DM. You either don't make insulin, don't make it at all because your beta cells are being destroyed, or the other option is you make it, but not adequately. You make it, but it's not functional, or there isn't a functional insulin receptor, etc. That's really what we're talking about for type 1 versus type 2. And that's the rest of the lecture summarized right there. Let's talk about the diagnosis for DM. Now this is really interesting, and this is really technical as well. You're not going to be laboratory technicians, and I don't expect you to memorize this, but it's a good thing to know what the current American Diabetes Association paradigm is. How do we actually diagnose diabetes? The diagnosis of diabetes is based on one of the following, and this is shown in your book. You either need to have more than 1 fasting plasma glucose level greater than 126 milligrams %, or 2 plasma glucose levels in 2 hours in the oral glucose tolerance test greater than 200 milligrams per deciliter, or number 3, a casual, and that means any time of the day without regard since the last meal, postprandial, of more than 200 milligrams per deciliter of whole blood. And you need also with that the symptoms of DM, the polydipsia, the polyphagia, the polyuria. The patient is coming in to see the doctor. Look, this 3rd category, this is the patient coming in because they're getting up in the middle of the night and they're urinating excessively. They're hungry all the time and they're thirsty all the time. And it's so remarkable that it drives them to the doctor because that's all they can think about: peeing, eating, drinking.